Are you frustrated because all of the healthcare providers are telling you need to amputate your mother's leg because she has an infected ulcer? Today, I'm going to tell you that there are 3 ways that I've used in my practice how to save a leg and avoid an amputation. I'm Bienstock. I'm a board-certified plastic and reconstructive surgeon. My specialty is wound care in the home, and I'm here to help you. So I've seen many patients over the past several years that have had ulcers, or we call wounds on the feet, and diabetics, or people who don't have good blood flow. And a lot of the people in the medical community, at wound care centers, vascular surgeons, have always pushed for an amputation. Now, that is the correct answer based on clinical experience, academic evidence, but a lot of people do not want to have an amputation, or there's such a high risk to have an amputation in elderly patients. So I'm going to go over a few scenarios that I've dealt with that fit this model. So the first patient is an 86-year-old male who has Parkinson's disease, dementia, and he had poor blood flow to his feet. He had potential revascularization, meaning they did a procedure to increase the blood flow to the foot. He still had wounds on his feet. They got infected. Everyone was pushing for an amputation. I told the daughter that we can probably avoid this if we try different things, but I can't promise it. She understood the morbidity, meaning the complexity of doing an amputation. Her father would be absolutely missing both legs. He had severe infected ulcers on his feet. He had diabetes. So this is what we did. Number one, because they were infected, we were able to get him intravenous antibiotics in the home. This was to address major infections, which was we call acute osteomyelitis, or infection in the bone. Secondly, I was able to clean up the wound by doing surgical debridement. The third thing is on one heel, I was able to do something called topical oxygen therapy. What that is increasing the oxygen concentration that gets to the wound. Something that's like this is called hyperbaric oxygen, meaning you go to an actual chamber where they give you increased oxygen tension, which increases the blood flow, actually delivers good metabolites, and was able to create new blood vessel growth as well as increase blood flow to that area. Since this patient was not able to go to a hyperbaric chamber in a facility, we were able to do something called topical oxygen therapy. And what that is you put a bag on the foot, I'm not lying to it, it's basically clear, almost like a garbage bag around the leg, and hooking up to oxygen machine. The whole point is delivering extra oxygen to the wound, which increases the oxygen tension, which will lead to increased blood angiogenesis, or blood vessel formation, increased oxygen getting to the wounds, as well as reducing all of the bad growth factors that impair wound healing. We did this over a month, as well as surgical debridement and doing appropriate wound care dressing. On the left heel, we were able to heal it completely. The original wound care center was completely surprised we were able to save the heel. He developed a new wound on his right foot, on the side of his right foot, which was infected. We were able to put him on intravenous antibiotics again, and this prevented him from getting septic. The wounds got better on the intravenous antibiotics, but we had to do, the wounds got much better on intravenous antibiotics, which include vancomycin and cefepime. However, we needed some sort of solution to heal the wounds. So what we did is we did negative pressure therapy. We've gone over videos talking about negative pressure therapy, which is vac therapy, where I use the cork system. We were able to do that over several weeks, and the wound shrunk in size by 80%. Now, it was on the verge of healing. The problem was he ended up getting an infection or pneumonia in his lungs, which led to him a hospitalization. I was not able to see him because he passed away from sepsis due to pneumonia. However, we probably would have saved his leg as we did on the other side. Another patient I took care of is a patient in Borough Park. It's a Hasidic patient. He came home with multiple wounds on his whole trunk, the sacrum, the hips, as well as the heel. We healed all the ones on his sacrum and hip by surgical debridement, negative pressure therapy, as well as different wound dressings like collagen. The one that heel was severely infected. They couldn't do any sort of revascularization, either a stent, which increases blood flow, or hooking up different blood vessels, meaning going from higher up in the leg down to the foot, since he wasn't a candidate. Everyone was recommending amputation. The family did not want an amputation. So this is what we did. In 6 months fast, we were able to get him intravenous antibiotics. We started with a 2-week course of intravenous vancomycin. We then switched to Zyvox, which is almost like an oral version of vancomycin. That was able to keep the control of his acute osteomyelitis, the bone infection, under acquiescence, or at a plateau. After that, we did multiple surgical debridements. We did a combination of topical oxygen therapy for several weeks, followed by good wound care. We did non-adherent dressings. We were able to also use wet to dry wash, which is hypochloric acid, which minimized the bacterial load. Once we got the wound much better, we were able to switch to a collagen matrix. And over 3 months, we were able to heal the wounds. I can show you diagrams, which I'll show you at the end of this video. The third patient is a patient that has diabetes. She's bedbound. She has a Charcot foot. She had non-healing wounds at both heels, both on the plantar foot. The plantar foot is based at the bottom of the foot. She was managed by a podiatrist who did multiple surgical debridements. He put a skin substitute in. The skin substitute did not work. Actually got the wound infected. She had a severe bone infection. So what I did is I was able to do an aggressive debridement. Now, we didn't require doing intravenous antibiotics since the patient wasn't what we call bacteremic. It wasn't really in the bloodstream. nor was she septic. So we were able to do oral antibiotics, which included a combination of Bactrim and doxycycline. We did this for 6 to 8 weeks. We did several surgical debridements, and then we started the patient on oxygen therapy. So she had approximately 5 wounds on her legs. We've healed 4 of the 5, and the other one that's on the back of the right heel right now is significantly improved and is almost healing. It's all due to the fact that we had coordinated efforts with the patient, the family, and the caregivers. So this is a prime example. You don't have to take everything that the vascular surgeon, general surgeon says in terms of amputation. Some people do need amputation. I don't want to make it look like no one gets amputation. If you're septic or severely, you have poor blood flow and there's major gangrene that's infected, sometimes you can't do these salvage mechanisms such as oxygen therapy or IV antibiotics in the home. There may be such poor blood flow that you can't save the foot, or the patient has such severe pain due to poor blood flow. So those are reasons why you can't save a foot. You would have to do an amputation. But most of the patients I'm dealing with have multiple morbidities and comorbidities, meaning they have diabetes, they have vascular problems, they have dementia. And these patients are not oftentimes great candidates for an amputation, or the families would really like to bypass amputation. These are salvage maneuvers to really avoid an amputation. Maybe these patients can't walk, but my one patient I went out at the end who has a Charcot foot with diabetes will be able to walk after aggressive physical therapy. All the examples show you that really with pushing the envelope, meaning doing intravenous antibiotics, doing either topical oxygen therapy, which is increasing the oxygen tension, or negative pressure therapy, you have a chance of saving the wounds. And we're able to heal, in 2 of the 3 patients, we're able to heal the wounds. And the last patient, we're all on the verge of healing all 5 wounds. So I want to know that this is possible. You have to have a coordinated effort. I focus on the 3 C's, which is coordination, consistency, and collaboration. You have to think outside the box. You have to have a really good caregiver team, as well as a healthcare team, and someone who's aggressive and entrepreneurial in wound care. This is something that you can do. I'm here to help you. If you need my guidance on how to manage either diabetic foot ulcer where they're pushing amputation, wounds due to non-pressure ulcers due to poor vascular flow, I'm here to help you maybe come up with other suggestions other than amputation. If you have any questions you want me to be involved in your loved one's care, please reach out to me. I want to focus on the most important thing. Healing starts at home. You're already on your way, and tomorrow will be a better day. Thank you so much. Make sure you subscribe to the channel, and please pass it on to all your friends. I look forward to our next episode. Thank you so much.